Hello.
Hi, Tomas. How's it going?
Good. How are you doing?
Oh, I'm doing all right. Just
Are you
hold
coming or going to a trip soon?
I just came off a couple of weeks of service, so I'm still
Uh,
trying to figure out which side is up. Oh,
nice, nice.
yeah, yeah. But I haven't. Need to. I need to go to Rwanda at some point this fall, but I haven't quite worked it out yet. I have. I have. The our NIH staff.
Mhm. All right. For some reason, it keeps going in and out. I'm not sure if that's my
Oh,
connection.
do you think it's my earbud?
Yeah, it's like cutting in and out with your audio.
Really?
But
Okay.
I can hear you now.
Okay. All right. Let me know because I have full reception. So
Yeah, I'm not sure what's going on.
yeah. Um, Let me know if it's still but yeah, the NIH staff are going to be in Rwanda, in, I think October, but I haven't gotten any confirmations and stuff. And
Nice.
I have several more weeks of clinical stuff in October and the NIH panel review panel. But I have time to go out of travel for 25 hours in each direction.
Yeah,
But
it's
oh, no,
never fun.
I can't squeeze that in. So try to figure out when I can, when I can make that. So, but that's fine.
Nice.
Yeah.
I
How
actually
are
had
you
a
doing?
question about.
Yeah.
I had a question about the book chapter really quickly.
Yeah.
Um, so I'm working on your section where you had the area here. Let me see if I can move this to the. Let's see. Yeah. So right here where you have the like how do we create one from a for an organization that doesn't have one? I there was a paper in the docket that you had that I kind of referenced, which kind of does the
Uh-huh.
level and the domains and stuff. And then for the DCP and WHO recommendation, it's just off of the 2005 uh, uh, script that the WHO published, right? Where they have the different tiers. Because that's the only thing I could find. Or you
Uh,
know what? I'll email you so we can talk about this like more formally.
yeah. Yeah. It's so put it together the best you can and then we can talk about
Okay.
it. So um great. We've got some of our staff joining in there. Sarah and Taylor are some of our medical students. I've sent Liz, Liz, were you able to send this calendar invite to all the other Hawassa folks or no?
Yes, I did. I don't know where they would be, but I know that they did receive the calendar invite.
Okay.
Yeah.
All right. See if I can send them.
You guys are third year medical students or fourth years or?
We're second years.
Oh wow.
Yeah.
Like going into your clinical year, second year, or like beginning your second year?
We are beginning our second year, but it is also our clinical year.
Oh, interesting. That's a little different than my medical school.
Yeah.
Nice. You guys are interested in global surgery or surgery in general?
Yeah, I mean, I'm interested in surgery for sure, but I like the aspect of global surgery, so I want to incorporate that into whatever I end up doing. So,
Yeah, I feel like that's what I've like learned in my short time in the fellowship is that my idea of what global surgery was like a small aspect, and that like global work is actually like could be done with any profession in the medical field. Like they like you can help in any way. So I applaud you. I mean, I think when I was in medical school, I was like so like narrow-minded about my career in the future, and I was just like surgery is it, and that's it. And I feel like the older you get in residency, you're like, oh, like what do I want my life to look like in the future? And I feel like that's what you guys are doing right now, which is nice.
Yeah, hopefully we're trying to figure that out.
Great. Well, I have pinged the rest of the Ethiopian team. I know that today is the Ethiopian New Year, and I know that our earlier meeting got canceled because of that, with the Ethiopian folks. But I am not sure if U.S.-based Ethiopian partners are around or with the issues with that. Meanwhile, that's fine. We'll just start, and why don't we just do a quick bit of introductions just so that we all know who is talking to, and then Tomas, why don't you then get started about it? So why don't you go ahead, Tomas, and then I'll kind of just cycle
Okay.
the screen.
All right. My name is Tomas Tesfasilassie. I'm a PGY4 at Columbia University. I'm in my research years, and I'm one of the ACS fellows for this year in global surgery at the University of Utah.
Okay, Taylor.
Yeah, so I'm Taylor. Like was mentioned, MS2 starting clinical years. I am one of the co-presidents, I guess, of the Global Surgery Student Alliance chapter at the University of Utah. So happy to be here.
Great. Sarah.
Yeah, I'm Sarah, and I'm also one of the co-presidents and an MS2. I'm very interested in global surgery. We were kind of talking about that before, but really want to incorporate that into my practice. So also happy to be here.
Valeria.
Hi, yes, I'm Valeria. I am an MS2, also co-president for this chapter, and excited to see how we can ramp it up this year for our fellow classmates.
Great. Liz.
Hi, I'm Liz. I'm the program coordinator for CGS. I am also again an undergrad. I already got a bachelor's degree from the U, but I'm restarting this semester, working towards another one. Don't know the major yet, but I'm exploring, seeing what is very comfortable for me.
Awesome.
Hi, I am Hafsa I'm a research program manager for CGS, and my background is MPH with global health. Good to meet you all.
I see Dr. Dodgen just jumped on, and Dr. Nunez just jumped on. So we're just doing a quick round of introductions as we were kind of giving all the students a chance to kind of introduce themselves and meet all of us. Dr. Dodgen, would you kindly introduce yourself?
Yeah, sounds good. So hi, I'm Chris Dodgen. I'm a trauma and acute care surgeon in Milwaukee, Wisconsin. I've been involved in some of the projects that will probably be discussed today for a number of years in collaboration with Dr. Jayaraman and the American College of Surgeons. I'm happy to be here.
Dr. Nunez?
Sure. I'm Jay Nunez. I'm also a trauma and acute care surgeon. I'm here at the University of Utah. I'm doing work in Mongolia and Ghana. So nice to see you all.
And on that note, starting next week, this is a new initiative at the University of Utah. We're starting a multidisciplinary global health research grand rounds that's really across the university and across various schools and colleges at the university. everyone from chemical engineering to infectious disease. And actually, Dr. Nunez will be our inaugural speaker. For the students, there will be lunch. So we'll send more information out about that. Great. So Tomas, why don't you take it away? Tell us what the project you've been working on. This meeting is a recurring monthly meeting to basically keep track of the projects that we have going in Ethiopia specifically. There are multiple projects. Several of our institutions have together to set up this fellowship. Tomas is. Go ahead and take it away.
Yeah, so for those that joined late, my name is Tomas Tesfasilassie. I'm the PGY4 from Columbia University doing my ACS Global Surgery Fellowship with the University of Utah. Today, I'll do a little bit of an update on the works. And for the people that don't know, I'll give a little bit of background of what's been happening in the past month or so. So there are 3 main projects that I am working on. One of which is Hausa pre-hospital system revamping and improvement. Another is improving the REDCap system that Hausa University is currently using with the collaboration with the University of Wisconsin. And then my last one is creating a laparoscopic skills training curriculum. So for the pre-hospital system, this is a project that is still awaiting IRB approval. As most of you know, we got the ACS Hope Resident Research Scholarship, and the AAS grant was just recently submitted. I talked to Faye, and she is going to submit that Hausa IRB either this week, but definitely by next week. And then once that is approved, which Dr. Belai is already aware of and said he would help us push it through, then we would submit the one for our home institutions here. While we were in Ethiopia, what we've kind of done is figure out who all the stakeholders are and get their contacts and kind of talk to them about what the pre-hospital system in Ethiopia is currently, and kind of understand how we can improve it, which helped us with our IRB. So currently we're waiting on things to be approved, but we've already kind of laid the groundwork for the work to be done once the IRBs are approved. The other is the REDCap. There's kind of 3 main areas that for this project. One is a retrospective data entry, and a bulk of the charts that we currently have have been retrospective. We're running into an issue of people that are submitting this information onto REDCap, not knowing what other people are doing. They were using a spreadsheet to have all of the names on there, but there was no way of like telling which charts were missing, which ones were duplicate. So what we've been doing right now is actually going through all of the retrospective data that has been entered into REDCap and figuring out which patients on our spreadsheet are actually missing and which ones we can find. We've noticed there are a few areas that are an issue for us to gather charts, one of which is when the charts are given to the chart room, they can be placed in a lot of different ways. And in a lot of different locations. So a chart that you ask for this week, you can find next week, but you won't find the week after, which is one reason that we want to know what we're missing so that we can go back and ask for them again, because I'm sure we'll find some of those charts that are currently missing. And the other is a relationship between the chart room and the general surgery department, where the person that was actually getting the charts was running through a lot of hoops and making it very difficult. So we try to streamline that by having a letter from Dr. Belai saying, these charts are acceptable to get, which has made our life easier in that sense. So that's one aspect of the project. The other one is the complication sheet. They have a very complicated system of like gathering these complication sheets. And the way that it works is basically the patient has surgery, their name gets written into an OR surgery book. And one of the research residents takes a picture of that. And that's one way of us to figure out which patients have been registered onto REDCap that have had surgery. But the complication sheet is filled out by interns who are only general practitioners that are only in the department for about 3 to 4 weeks, and that don't necessarily have a tie into or an invested interest in improving this data gathering. So one thing that me and Dr. Belai worked on before I left was actually training the nurses who are discharging people to look for the complication sheet so that the patient can't leave until the complication sheet is filled by the intern, or there's a way for the nurse to say, oh, the intern didn't fill this out, let me rip it out and give it to the intern. And the other way is for us to have the other issue was the complication sheet wasn't being found maybe like 50% of the time when the interns are looking for it. One, because the sheets are usually in Dr. Belai's office, which is sometimes locked and only attendings have access to it. But the other is there's not really communication between the residents that are doing the research gathering and the interns. So another thing that we did was an intern boot camp. So whenever they're coming on to rotate into the Department of Surgery, Dr. Belai and I would talk to them about the importance of the complication sheet and filling it out. A few months ago, I think our complication sheet, the missing was about like 50 to 60%. And I just checked yesterday and we're about at 32%. So we're improving in that aspect, but that's definitely one thing that we need to do better and something I want to improve this year. And the other big task for this year is to establish a server. So Mr. Betsagao is a Hawassa IT. He actually has already downloaded most of REDCap into the servers of Hawassa University. But the problem is there's no continuous energy source, which is one thing that we've been trying to figure out, which we're hoping a PC system that's placed in there with a generator can suffice for that. And two, the interface is a little bit different than when an American institution tries to have REDCap. So currently I'm working with him and Vanderbilt University to see if there's anybody in the IT department there for REDCap that can help us get a server. And the importance of this is so that the people in Hawassa University can do their own studies without having to go through the University of Wisconsin or having their own data placed in another university's server. So this is one project that we think will advance the REDCap in Hawassa and help them create more projects in the future. And then the last project that I mentioned is the laparoscopic skills training. This is just a picture from one of my skills labs. One of the big things that we want to work on this year is creating an actual curriculum. So when I was there, a lot of my time was spent trying to get people to come into the skills lab. And that was because there was a lot of misconception about who can come to the skills lab itself. And there were a lot of people that were saying only seniors could come. So, only chiefs basically could come to this, which was limiting our numbers. But once we expanded that and opened it up, we got a lot more people. So to date, we've, what my vision for this is to follow the FLS skills test curriculum and kind of teach them those 5 skills and then do more open lab concept type of teaching. So we've taught 15 residents task 1 and 2 of FLS so far. And what I've been working on in the past month and the past few weeks since I've been back from Hawassa is kind of coming up with a way for us to have sessions when people from America are not there. And what we decided to do was to focus on the 3 attendings that are trying to do more laparoscopic cases. So Dr. Zara Sanai, who's a PD at Hawassa, Dr. Belai, who's a chair, and Teddy, who is an attending there. they're the core people that are really on board for the laparoscopic curriculum. So what we decided to do was to have them do a session each maybe once every 2 weeks, so that we don't burden the attendings out too much. And then, this is something that we can discuss as a group, is kind of, what about the in-betweens, right? So there's 15 residents. There's going to be 5 residents per session. So it's about a month and a half to 2 months between sessions that residents have without any laparoscopic training. So one of the ways that I thought, we can keep tabs is to kind of mandate that all the residents would have to sign in to the skills lab at least 5 times in between their 2 sessions. So in 2 months, you just have to go there at least 5 times on your own or with a buddy and practice. And the other thing that I was thinking about was kind of having time trial of the previous tasks before you can move on to the next task. So, a lot of FLS is built on top of each other, and you're really not supposed to move on to the next task without mastering the previous task. So another thing that we were thinking about was, when they come in for task 5 or task 4, let's say, we would time them on task 1 and 2. And if they don't complete it within the allotted time, then you would keep them in task 1 and 2 and just have them practice for that day. And then the next session they come in, hopefully they practice more and they'll pass the time, and then you can teach them the new session. We're hoping our next session will be with Dr. Belai on September 18th. So that's kind of all the updates I have. So
let's talk about each of these projects distinctly, Tomas. So for the last project, I know that you had mentioned last month that you were actually trying to, the very last project, that you were trying to develop a laparoscopic curriculum and a guide. What's the status of that?
Yeah, so I'm still waiting on Dr. Belai to tell me which chapters he actually wants me to write. So the way that their academic year works is basically every February they switch. So when the new first year residents come in, he's trying to have a boot camp, and within that boot camp, he's trying to have a laparoscopic actual 2-day intensive session. He's told me that he's written a few chapters of the book already, and he wants to work on writing different ones. Me, Zara Sanai, and Teddy are just waiting for him to tell us to delegate which parts of the actual curriculum he wants us to work on and write up. Yeah.
Okay, that sounds good. And then have you had a chance to look at our Thinkific platform that Dr. Price has set up that's available for staff in Ethiopia and Cambodia? Because there are a lot of videos for specific operations. And at the least, that kind of a content would be useful. And so mandating that the residents go 5 times, maybe it's a matter of saying, have you watched this, and can you, either demonstrate it or answer some questions about it. Something that sort of almost gamify learning laparoscopic skills. Is there a thought along those lines, and have you looked at what we've set up already for the Cambodia project?
Yeah, I've looked at some of the videos. From what Dr. Belai has showed us, it's kind of like what I understand is he wants me to basically put the training that I'm doing, like all of the FLS stuff, into Word format and then put it into a document so that future people can learn like the tips and stuff that I'm teaching people, or the tips that are online. Me and Dr. Zarasanai, when we were talking about the kind of the mandate for the required training, the reason that we did that was because of the time that you have between 2 skills sessions. You'll have at least 2 months. And, we're worried that since there's not any laparoscopic surgery really happening in high volume, that in those 2 months, the people will just basically be watching videos and not having hands-on training on these tasks. And when they come in to learn a more advanced task, you're kind of having to regress for half of the session. And so
Yeah.
that's why we were thinking about having the mandate just as an early on thing.
Yeah. You know, mandates are just tricky. You know, how did you come up with the number 5? And if it's 5 in a row the week before your next training, that's going to be very different than if you spread out 5 sessions over the course of 2 months. I mean, just think about learning how to ride a bike. If you rode it 5 times in the last 2 months or 5 times in a row, who do you think is going to actually have skills retention, right? Like, so some of it is how do you think about transmission of skill? It's repetition. What do you need for skill repetition? You need the right, you need to have understanding of the content, and then you need to have the right equipment. And what can you do to enable both? And we can ensure the right content by making sure people have watched specific videos and understand what to look for in those videos. And then in terms of the skills, it's, as you mentioned, you know, kind of figuring out time trials of specific tasks, or assistant operations. But you know, I think you have to kind of plan that out a little bit more than just than like 5 times and possibly a time trial in order to be maximally effective. And I always, I know the reason I emphasize that is that all these people have limited time, and so you really want to maximize what they're getting for that time. And if they go 2 times and they don't find it useful, they're not going to go a 3rd, 4th time. And so paying attention to that is really useful. Dr. Dodgen, I think you had a comment. And adoption of any of the laparoscopic courses. Thought of having the residents video themselves doing the skills to provide feedback. I think those are great questions. What do you think, Thomas? Is that something, would it be helpful to have them learn the skills and then send videos? I mean, maybe some of our medical students would be interested in helping us create a video evaluation process where we're able to evaluate their proficiency in doing certain tasks or something along those lines.
Yeah, they can record themselves. We were talking about the recording themselves too, and in the actual like boxes, the Ethicon boxes, you can technically put your phone upside down and record yourself doing it. We were thinking about that also, but we just don't have enough boxes to give to residents. They can technically have somebody else be there with them and record them on the screen itself too, and that's something that we were talking about in terms of like having different groups and having like a few residents per attending, and you can send the videos and kind of get feedback on that. We haven't come up with like a best practice way of implementing that currently, which is the difficult part of it, because like you guys said, the residents are just so busy that I just don't want to like give them too many tasks to do when like learning laparoscopic skills is also a huge task for them, you know, because it's like skills they never see. So
Dr. Dodgen, do you want to explain a little bit more about what you're
absolutely. So, just to kind of mention, the Intuitive Foundation, so the robot company, they have a foundation which they invest in various sort of different global health initiatives. One of them, I believe it was a couple of years ago now, they basically created a contest for low cost education innovation to provide new skills training in low resource areas. And one of the groups that, and I'll find the website and or the link to it and post it in the chat during the rest of the meeting. But one of the primary winners of this for them was a group out of Ethiopia that created a laparoscopic box trainer out of like a cardboard box with, again, a simple ruler and scissors sort of cutting out the specific port sites, etc. There's a handful of other items that you need, but not a lot, and most of it can be is locally available. And then the other novel piece to it is actually their method of both training and assessment. So it was sort of a somewhat of a pyramid scheme to some degree of that people would video themselves doing whatever task or whatnot that it was, and then they would send that on to at least, I think, 3 or 5 additional people, and then those folks would do the same, and ultimately you'd end up getting all this feedback from the folks that you send it on to, and it's a way to, I guess, provide expertise or feedback using a community model. Anyway, the idea is that type of innovation is scalable, and it isn't necessarily scalable having Tomas there every couple of months doing directed training, etc. So anyway, they've had a fair amount of uptake and success, and so that may be something that's worth kind of looking into if that's of interest. Again, is sort of a next step of this project. I think what's been done with the ThinkEffect platform and the impact that that's had, and the trips that have gone on with training the faculty, I think have been great thus far. But if we're thinking about sort of how do you scale it up the entire residency, how do you teach others in Ethiopia that don't have ready access to the information? Anyway, I'll post the link and we can talk about it a bit more after.
Please.
Yeah, that sounds like a great potential addition to this program. And I wonder if, Tomas, if you can meet with Dr. Belay, and one, give him a tour of the ThinkEffect platform, and then 2, if you can scope out what Dr. Rajan is referring to and kind of share some of that.
Yeah.
And then maybe there's a hybrid, training and assessment program that can be created for this group and out of it. So, I think that could be valuable. It could be, and perhaps learning has to be customized, right, to the learners, and the resources they have, and the ability they have to spend time doing it. And it maybe some kind of box trainer like that would be useful that they can take home. Maybe every single resident should have something like that at home, and they don't need to come to a simulation lab at the hospital that's locked up that they have to access to use. Dr. Nihan Lin from Stanford is a CT surgeon, set up a global surge box, which is to help create a box of equipment. And I actually just recommended this to one of our third-year residents, fourth year medical students just last week. And it's just, you can buy a set of tools on Amazon, create a box that allows you to train, and they have various videos of various operations, and you just learn how to do that. Do all those. It's all open surgery. It's not laparoscopic. But the goal with our project is to de-escalate the access to the equipment, to have trainees have it at home, because it's so hard to get to the hospital and get to the right room and have time for all of that. But if you're for 10 minutes at home, it's so easier. So there's some ideas there that need to be sorted out. And I think for the next meeting, if you could kind of work towards coming up with some of those plans so that we could then figure out how to move forward, that would be great.
Yeah. Thanks. I just saw your message, Dr. Rajan.
What about can you go back to the previous project? Anybody else have any other comments on this specific project, by the way, before we move to the other things? Okay. Yeah.
Oh,
Sure,
sorry. I was curious for REDCap, what studies you have lined up and ready to go.
Sorry, what did you say?
What are you going to use REDCap for? Do you have projects in mind?
Oh, for me, I mean, what we're mainly using the REDCap for right now is to capture every single surgery that is happening. the hospital itself is a tertiary hospital, so they get a lot of like vascular and like more complicated cases than bread and butter, like colis. So right now there's actually not much research being done off of the red cap because of how sparse the data has been. And so my hope is by December, we can have uploaded all of the retrospective patients and just solely start focusing on the prospective. Because right now we have 5 research residents. There's there's 2 people working on the retrospective data. There's 2 people working on the prospective data entry, and there's 1 person calling all of the follow-ups on like 30-day follow-up. And it's just very cumbersome on a few people. And so the data that they've been gathering isn't robust enough, like at least from what I've seen, not robust enough for somebody to do a huge project. But there are some things like thyroid surgeries that people have taken some of the data, because we have about like 30-40 patients and have looked at it. But right now, to my knowledge, there's nobody that has done any research off of the REDCap data for this year. And I've been working with the 2s and 3s because this is a year that they have to come up with their research topics, and seeing how the REDCap can work to help them out. So that's something that, is like a newer development for us, but something that I'm hoping by December and for the new incoming class, for the new academic year, we'll actually have enough data for them to say, can I answer this research question with the REDCap? Because right now they have to come up with the research question, figure out how to data gather, which is basically like wait for that patient to walk into the hospital and then like follow them all the way until discharge, make sure they have their chart with them, and like copy everything down and then return the chart, which is like not feasible if you're trying to do a lot of research. So we're trying to beef it up, but it's just a slower process than I would have thought.
Yeah. So you're starting with creating a registry.
Yeah. So we have a registry. We have about 900 patients there, but there's a lot of like duplicates. There's a lot of data that is entered incorrectly. So it's just kind of cleaning it up a little bit, and then hopefully for the new academic year, they can actually start using the data much more than they are right now.
Great.
And we're actually the I will give them props on is they're catching about like 95% of every single patient that has surgery, which is, the first step of any data gathering is like making sure that they get into the database. It's just a downstream part that we're trying to fix, because there's just so many people that are involved in the care, and of course it's not all electronic, so it's not very easy for us to get this data. So I'm trying to help them, but also have them come up with solutions too, because ultimately they're going to take over this REDCap. And right now they're like relying on me very heavily to navigate REDCap, which is, I could do that, but I'm also trying to like show them how to do REDCap, which is also slowing us down a little bit. But I think in the future, that's going to be ultimately the best thing for them, because Haben, who's the main person that's doing this, he really didn't know how to use the interface. And so he would just wait on us to tell him who's like 30-day post-op to call. But we sat down and we worked on it, and now he's like doing it on his own and like calling the people on his own. And I'm like, yeah, those are the steps that we need to take to kind of transition this into your hands. So it's a slow process, but I think by the end of my year here, I think the REDCap will be in a better place for sure.
Great. Yeah, so there are 2 separate issues with this this perioperative registry that's using the REDCap platform. Right. So one is the process of gathering and inputting the data, and then the other is the process of accessing the data to analyze. I realized, we've talked a lot about the challenges and logistics of gathering and inputting the data. Are you doing periodic assessments to see what data is there to get a sense of how accurately it's being captured, or is there a process for that, or is that a one-off thing? Can you describe a little bit more about that?
Usually, whenever people have surgery, they write them in a surgery book, and Haben would take pictures of that and send them into, we have a like a RedCap research group, and he would send it in there, and I would essentially go onto RedCap and make sure all those patients are actually inside of RedCap. Trying to see the complication sheet is a little bit more complicated because one, it's only collected when a patient is discharged. So there are a lot that are incomplete, but it's difficult for me to understand, like, is this patient still in the hospital or are they not? Like, I look at their admission date, but that aspect is difficult. And there's currently no way to know very quickly, like, oh, this person got discharged, but there's no complication sheet. So one thing that I was thinking about was the nurses actually have a discharge sheet where they write all the patients that are discharged that day. And what I was thinking about was having Haben or somebody kind of send a picture of that every Friday or something. And then we can look back and say, okay, 5 people got discharged this week. We should at least have 5 more complication sheets than we did before. And if we didn't, like, where are the people that were missing? So that was the aspect of how to fix that issue. But for right now, we're only monitoring if the patient ended up on RedCap.
Usually, or often in many hospitals, there is a ward logbook. Like, this patient was admitted to this ward with this condition, X date, and then when they're discharged, that date is written. Is there not a logbook like that?
Yeah, so they have a logbook of all the people that get discharged on that day. But sometimes they don't write, like, the discharge day, or it's missed and stuff. But that is probably the most accurate data we're going to have in terms of how many discharges we're having on a daily basis.
Yeah, and to Dr. Dodgen's point about recall bias, if the patient's there for 2 weeks and then discharged, or you're going to have recall bias in both ways, right? You're going to have recall bias where you're missing complications, and then you have recall bias where you're remembering some complications. So you might remember the more serious complications, so then it looks like there's a high rate of serious complications, or you're not going to remember the simple complications, and then you potentially have a high miss rate of the milder complications. And is there a better way of looking at complications, or is there a better way of thinking about electronic medical record that's more integrated to their standard clinical flow? Is there any way this RedCap platform could be used as a part of their standard clinical?
I mean, I know that they can get access onto their phones, but I'm not really too sure if they can. I don't think anybody has tried to like have them do real-time complication sheet uploads onto RedCap. I think the idea was they previously had too many people that were uploading stuff onto RedCap, which made it very confusing, and so they scaled down, and it's kind of been working for them. But that's not something that we explored.
And perhaps it is something to explore. And I was about to make the similar comment to Dr. Rajans is suggesting is there a way that you can create some sort of a template to say, I was thinking, and I don't know, Chris, if you're thinking along these lines, but I was thinking more like, oh, does your patient have a pneumonia or a urinary tract infection or a wound infection today? If yes, like to have that kind of an assessment for every patient every day, so that then the answer is yes, then there is then maybe there's a link, there's a set of data points that are then collected, where it is perhaps more in real time to be able to access that information, as opposed to waiting until they're discharged.
Yeah, that's something that me and Dr. Blight spoke about too, about like the charts might not have all of the complications. And he was working on a way for them to write it in every single progress note, like hospital, like notable events in the hospital or something, and have them kind of put that in every single note moving forward. Currently, they weren't doing anything, but I'll check in on him and see if he came up with a way to kind of have people writing the complications daily rather than an intern trying to remember what happened in the past 20 days.
Yeah, exactly. So it might be worth discussing that and exploring that in the next month. Is what are alternatives to capturing patients, and what are ways we can standardize that by creating templates for their daily progress note, creating templates that are daily just checklists, and then creating having the REDCap link that can be accessed from their smartphone, or having some mechanism where they send the critical pieces of information to somebody else who enters.
You're saying like if a complication happens today for a patient, like we need to come up with a way for us to have that be written down, like have a document saying that somewhere else, or
either somewhere else or in REDCap. So let's say you're the surgical resident seeing a patient. Your patient has a wound infection. You're starting antibiotics, and in your daily you have the checklist that has 3 questions. Your patient has a UTI, and you have to decide what complications you're interested in. Is it UTI, pneumonia, and surgical stent infection? Let's just say. And you're asked to think about that for every single patient every day. And if the answer is yes, then you send, maybe it's a text message to the group that says, MRN of this patient, here data of complication, type of complication, what happened. And then there's a person who could enter that. That's one process. Second process might be having an electronic medical record that is, having people enter into the REDCap, using that as a quasi
okay.
So that it's used on a regular basis. Is there any way that could be set up where it can be useful? Right now, the reason why many of these registries fail is that the people who are putting in data don't get any benefit, right? So that's the fundamental problem with these registries. There's no direct benefit. You're putting in some numbers into it doesn't even matter. You don't even get feedback of whether the number is correct or not, And so the more you can create a system where there's direct feedback that says, oh yeah, great, you have, it could be as granular as, hey, you filled in 10 out of 20 fields today, or hey, you've reported 5 complications in the last month, or your patients you've had of the 20 patients you've entered, 5 have had complications. Congratulations, this is less than average. Or I don't know. I mean, there's kind of different ways of tracking that and kind of positive. So we have to think about that more creatively, because otherwise, it's gonna be additional work on an already stressed human being. So.
To kind of echo those comments, I would say, or I guess one of my questions is can REDCap, or has REDCap been used to create sort of feedback loops or visualizations regarding data, and whether that's sort of regularly run reports and graphs that can be sort of auto-generated? I'm not as familiar or facile with REDCap. I know in terms of data entry, it works quite well, but in terms of sort of data display or data output, I'm less familiar, and so it was just I know that has been successful in other projects and other using different programs that allow for again, if you can pull up a dashboard, right, that shows, okay, this is your surgical volume, this is the number of patients who are discharged, this is your general kind of complication rates, or what's your case mix, or that type of stuff. That's the type of feedback that will be incredibly valuable for all sorts of reasons, and then prompt people to ensure that data is accurate.
Yeah.
And continue to provide the feedback to collect the data.
Yeah, I actually really like that idea, because it is actually feasible to create those graphs, and that's actually the only way I understand the percentages of like what's missing or not. And what you were saying, I think I can just do that monthly for them. At least I know Dr. Belai would really appreciate it, just so he can know what's happening in the department. And he's kind of been the one that I'm working with in terms of like doing the intern orientation, or like making the nurses involved. So, another aspect was like, I was trying to figure out how we can get like the daily teams involved in all this. And it's kind of a lot of what you guys are saying is kind of like a more instant, like we need the information now rather than later. So I think this might be a nice way for us to say like, oh, we had like 6 colorectal patients this month and only 3 of them got filled. And then we can go to the chief or whoever's running that department and be like, hey, like what's going on, or speak to the interns or whatever and see what we can fix. So I think that's something that I can easily do that.
So that there are 2 different aspects though. One is the missingness of the data and tracking that, but the other is actually the clinical outcomes. So you could, for example, create a weekly dashboard or weekly report of the dashboard that says, hey, this week, X number of patients had operations, X number of urinary tract infections were reported, X number of surgical site infections were reported, or whatever the data are. You decide, and that could be something that's generated on a weekly basis and reported right to the group to say, hey, here's what it looks like, and I would encourage doing something along those lines. And involving the nurses, involving and having a representative, having a team that's 1 nurse, 1 surgical resident, and 1 faculty who get that report and who are in charge of either getting that report or creating that report or interpreting that report. And have them be the champions of their professions. So that would be a method of engaging them on a regular basis. And once they start seeing the value of it, then the missingness will go down, because they'll start saying, hey, I'm seeing that my patients are doing well or not doing well, and I want to pay attention to this. And then automatically it'll empower them to track that information. So it's not like, oh, you're not putting in this information and we can see it, because that's more of a punitive system, as opposed to a system where there's more engagement, saying, hey, here's what the results are, and how can you benchmark this? Can you benchmark this by surgeon? Can you benchmark this by patient population? And that could be useful. So, for example, in the U.S., we get that kind of reporting periodically. Our clinical or quality officer typically would get that kind of information. The division chiefs get that information, and there's even peer-based. Right? In fact, if you look at, I think it must be Complications by Etokwande. One of his books, or maybe it was Checklist, actually talks exactly about how it's important to have this sort of peer-based benchmarking that then improves quality of care. So there's definitely some work that's been done along those lines, and it's just a matter of how could you do it in this context. Because quality of care is even more important when you have fewer resources, right? So you don't have waste. You can't have waste. you can't have these inspections because you don't have the ability to pay for the additional inspection or data. So just something about. And then and I see that our research program manager must have jumped off, but she has some experience with RedCap, so you can kind of connect with her also and see if she has that. So you can, other thoughts on how to look at quality of care or engagement, staff engagement. And then the last project is a pre-hospital one. I know you're waiting for IRB, but have you all thought about who you're going to interview and what questions you're going to ask and develop the interview guide and things like that, or surveys? Because those are all the next steps, right?
Yeah. We pretty much know everybody that we need to speak with because we said hello to them before we left Hausa. And we got that information through the chair of the emergency department. And then we were coming up with questions also about kind of to standardize what we're going to ask them later on. And we've kind of been formulating ideas about kind of like what information we would need from the different departments once IRB approval is done. So we've done some of those things, yes.
Okay, it would be, I encourage you to create an interview guide and then a survey, a list of survey questions. So because once you get IRB approval, you can move forward. And if you're ready, if you've done this in parallel, you can move much faster. So don't do it in series. Do it in sequence. Do it in parallel.
Additionally, along those same lines, we'd written in the ACS grants, and it's in development, is a sort of pre-hospital assessment tool created by the WHO. And they, I believe, we're creating kind of the final touches of review on it. It had to go through creating anything in the WHO system takes a long time. But the last I talked with Lee Wallace, who's the main person who's kind of reviewing this information, which was about a month ago, it was on his desk to kind of do the final review before it could be published. He was happy to share it with us. And so as we get to the stage where and I owe him an email to follow up, and so I can send him an email to kind of follow up on that aspect as well. To see it, is that survey finalized? And is that something that we can start taking a look at and think about how do we, or who do we disseminate that to? And does it fit all of our populations that we're interested in? Or is it only sort of assessing the hospital level kind of pre-hospital data or readiness, et cetera?
Would they be interested in piloting Ethiopia, Chris?
I think so. Ethiopia's been a nice pilot site for them for a number of other projects with regards to trauma. I did not specifically ask if that this could be sort of considered a pilot, but certainly easy to ask that.
Yeah, I think that would be great if we could pilot it with or for the WHO as an example of how that data can be collected. Or
yeah, so I think that
and then
next steps for that would be I can circle back by email and see if that's completed, and then it would probably be setting up an initial conversation with those who created the tool to better understand exactly how they envisioned it administered, etc.
Yeah, no, that's a great point. That was exactly where I was going. Was then it's a matter of, is that what we want to collect, and is there additional surveys that we would want to do that, or additional questions that we would want that would answer a bunch of other questions, and how would we put all of that together? So I think that would be a really useful project, is to understand what their facility readiness is and what needs they have, what vision they have.
Just for a bit of background for the either equity injury project or some of the work that you've done in the pre-hospital setting in Rwanda, have you done these types of assessments, kind of evaluate both the culture or attitudes towards strengthening pre-hospital care, but also kind of a basic resource assessment?
Not a resource assessment, but we published 2 papers in Rwanda based on interviews of key EMS leadership, key ambulance dispatch staff, the nursing leadership, the anesthetist leadership, and the policymakers to get a sense from them of what's important and what they want to what they want to see and their vision for the system, what they think that their main barriers are, etc. Not a what resources do you have on ambulances, where is your supply chain, that kind of thing. In part because that was already felt in Rwanda to be pretty well established. So our goals weren't to improve that. Our goals were more to improve the EMS coordination. But it's worthwhile to ask those questions. And maybe these surveys are, maybe they should be done in a sort of a tiered format. Like in a country that doesn't have any EMS, what are the questions you would want to ask? A country that has some EMS infrastructure, which maybe it's a modular thing. Certain modules are optional if you already have, you've already surpassed, checked off all of these, right? So I think I wonder if instead of like one survey, it really should be a survey with modules or concepts.
Yeah, like a core survey that you would expect it to, again, early stages, you would expect this level or whatnot. It's a little bit akin to right, the Utstein papers with regard to the Lancet Commission indicators and the project that Jade worked on in implementing in Ghana, right, is the different levels of sort of ideal data collection. So what you do when you're first starting out with a project, or when you have more resources, and then what's your sort of most ideal of the data that you'd be collecting, et cetera.
Yeah, absolutely. Like some of it probably Jade will touch on next week on this going rounds. Yeah, I think those are all important questions, and to not make it overwhelming for the folks in the country, right? Like you can't give them a 20,000 questions because that's not. And I think I sent some of the Rwandan papers at some point. Tomas, I think I sent them to you, so you may have the papers that we've done and take a look at what we asked and how we asked those questions. I can't remember, actually sent the interview guide that we used. And for the students, we had an undergrad who actually took and transcribed the interviews, helped do the qualitative analysis with so that was a great project. So she is an undergrad, brought that up as the first job. So a lot of great opportunities. All right. I think that's it for today. It's already time. So next week, as I mentioned, Dr. Nunez, we're going to have it'll be a hybrid session. And then we'll send, for the Utah folks, we'll send you guys flyers. You can share that. And then Liz and I are also making lists for what we have sessions. And then Tomas, I think you have some sense of like what are the things to work on to follow up on for the next month.
Yeah, this is very helpful. Thank you.
Yeah, it's good for us to kind of discuss and brainstorm and see how to move some of these projects forward. If you don't know you're stuck on something, kind of discuss and share and brainstorm. So you can look at some of the links Dr. Nugent sent.
Yeah, I copied them.
Yeah. Great. Any other comments from anybody else? Okay, awesome. Well, thanks everybody for making time to join today. See you next time. All right.
Thank you.
Thanks, everybody.